important means for you to gather marks possible for you lah actually sebenarnya. When you are given MCQ, you can you can try your error, but this is when you given like an essay, you can put your knowledge, bulk of your knowledge in the essay that you really master in, and I know that you have done it many times now. You have already started doing your essay, and hopefully that you will have the idea of putting your minds into your essay. Yeah. So the first topic, let me share my screen with you. Okay, the first topic is, wow, number 2. Okay, since you're talking about essay, most of the time we are worried of our handwriting. So look at my handwritings. Now I'm not giving you a good one, a type one. Look at my handwritings. Yeah, this will be the same that we are going to do when I look at your handwriting. Yeah, so remember, it's not just one handwriting that I'll be looking at. For the examiners to look at many more handwritings. Yeah, so this again, the topic here is a 36-year-old G3 para 2 with a recurrent IUD at 30 weeks, currently at 7 weeks, yeah, and discuss the management of patient. So remember, when you're given a clinical scenario, actually it is bonus for you. A majority of time, you should pass the exam lah. You should pass the topic given to you. Yeah, because many a time you already have 4 years of training when you sit for your exam. So actually that you've got a lot of knowledge in managing patients clinically. So you really should put your effort, yeah, to do the best in your clinical question. So this is again, I already ballooned up. Yeah, I balloon up which are the important points here. So again, here is the 6 weeks. This is important. Why? Because this is the advanced maternal age. Yeah, and she is G3 para 2, no living child, but she has had 2 IUDs happening. Yeah, beyond the age of miscarriage. Yeah. And this is again a recurrent IUD at 30 weeks. This is the 3rd trimester, and why this is important and balloon up again. And currently, this woman is at 7 weeks, meaning that she's already in first trimester. She's in the first trimester. So the question is simple. Just discuss the management. Yeah, discuss management. Management je, discuss je. It's not critically ke apa, it's only management. Yeah. Actually, you people should get good marks for this one. So here are the issues. Yeah, so I've list down the issues here. So you've got to look both the issues. The issues is on the first one, how to manage her, is that you want to look at the recurrent IUD. Yeah, so issue number 1 is recurrent IUD. Number 2, she's currently at the IUD happens at 3rd trimester. And again, this woman has no living child. So this is the past. These are the past issues of the problem. But the current state is that she is only in first trimester, and she has got, on top of that, she has got advanced maternal age. Yeah, and so what you're going to do is that you're going to, in your preparation, you should put all the causal factors of the 3rd trimester IUD. So you can divide into maternal and fetal causes, right? So put the number 1, maternal. The congenital chromosomal anomalies, it should be in the fetal, yeah? So in the maternal, be the medical disorder. You can list down all the things. And I'm sure that you have list down all this, yeah? Don't forget about PLS, severe thyroid disease. You all usually be complacent of this thyroid disease, but can have a problem with severe thyroid disease, yeah? And again, you can have polyhydramnios due to the secondary to diabetes in pregnancy, but you do not know actually what happened in the previous IUDs. Can be because of prolapse. It was not mentioned here, so don't take things for granted. This can also be due to prolapse or whatever. And in the fetal side, case of, again, the congenital chromosomal anomalies, yeah, and which cause the hypoxia. In IUGR, don't forget, you can have all the causes of IUGR, including infections, maternal disorder, and also majority important thing is the unexplained cause. And don't forget about that. Okay, the next one, the next step we're going to move is the management of the third trimester. So going down to the second page. Sorry, masa I arrange this tu salah, terlompat. Yeah, so I want to go to the second page. So in second page, again, introductions are before marks. So you can have variable marks for the introduction. It can be between 2 to 4 marks. So in this case, I give 4 marks over here. Yeah. So in the management part, the introduction, you want to list down the IUD in third trimester, most unwanted event. You want this to happen to any patients, yeah, not just to patient but also to family, negative to psychology, phobia, future pregnancy, yeah. Again, recurrent can be about 8 to 10 times later. In the worst scenario, you can have a recurrent event, yeah. So you must investigate, and majority of the cases remain unexplained, between 50 to 60%, and despite postmortem. This was an evidence base, yeah, which I will give later, the journal that you should code. You people cannot, not just this is exam and OG exam to becoming a specialist. So no, not just a grandmother story. So you must quote some findings from your journals or whatever that you have read about. Yeah. So now we move on to the next main text. So in main text, I give you 14 marks. Yeah, establish the cause. And then third trimester, LD, 4 marks, I give you history. And remember, management also involves history. So all the medical condition, yeah, previous investigation, the previous history, remember? Yeah, and according to history again, apa-apalah, yeah, blood hemoglobinopathies, placenta insufficiency. And now next we move on to the examination. I think patient too obese ke tidak, failure to detect IUGR, maternal physical, ada mak tu ada achondroplasia ke, any disabilities in the mother, should exhibit that in the examination. Any signs of medical, signs of medical illness, xanthomas and fungal infections, and then also the paragraph. Okay, now we move on to the third page. The third page is all about the management starting 7 weeks. Yeah, so EMA apa nak buat? So starting from that, you can have basic investigations, cervical length, HBS, apa-apa maknanya lah. And majority of you have got this. Yeah, maternal anticipate cause a problem, apa pun dengan molecular weight, steroid, okay. Yeah, we have done that. Many of good as well. Yeah, anti-scan possible, and becoming a mid trimester, you want to use a DT scan. Okay, are there any value of prenatal screening here between 28 to 24 weekly shared care, anticipating premature delivery, and aims of delivery. So last but not least is the conclusion. Must your conclusion can carry about 2 marks or even 3 marks. Yeah, so don't forget about that. And in summary, what do we achieve this? Yeah, from this, can see that your clinical question actually, as mentioned earlier, when this is given to you, it should be answerable. Yeah, don't miss this boat. Yeah, don't miss this offer. You should grab this offer. Yeah, and should approach it systematically. And each paragraph in this, I gave. If I put together, I can have five paragraphs. Yeah, with all the systematic how to approach it. Unfortunately, 11 fail out of 19, which make about 68.9%. Yeah, kenapa? Because not enough points. Sometimes write too long, tapi all around the bush, benda yang sama, repetitive points. Yeah, but you had 3 good essays. Mungkin I terselak nama tadi adalah itulah yang paling among the best. Yeah, I can sorry I forgot to mention here because it's a good essay, ya. Siti Atika Rosli. Tepuk tangan, ya. Anybody can have a look at Siti Atika punya. Ni go and have a look. Have ni tengok macam mana dia tulis, cantik essaynya. And we've got another 2 more good essays. And on contrary, we also get 3 bad essays. People, if you get 6 and 7, that are among the worst, yeah, marks for the essay. So please, don't go and improve on this, okay? So I think that would be all, yeah, for the first essay. Any questions? Any questions? Okay, kita masih lagi ada masa kan?
Ada kok.
Another 10 minutes, kan?
Yes.
Okay, so actually, if you look at this, among the marks that I've given here, on the paragraph 1, actually we were on the introduction. Yeah, paragraph 1 just on introduction. I give you what should be written on the paragraph. Yeah, paragraph 1 is introduction. Paragraph 2, taking or stating on the courses, yeah, to establish the course of 3rd trimester IUD, and that is the 2nd paragraph. This including the courses that you have list out this earlier part, yeah, maternal and fetal courses too. I give that 4 marks for that, yeah, according to yeah. And the 3rd paragraph would be between history and examination, yeah. I give 3 marks for that. Ya, banyak juga. Mana you boleh dapat banyak markah kat situ sebenarnya. Ya. And the 4 marks, the 3 marks, kalau dapat banyak markah kat situ sebenarnya senang pilih benda tu. Benda tu you can you all look like patient every day, you examine patient every day. It's just putting your minds into your thoughts into your writing up, ya. And macam tadilah, you must mention achondroplasia, mak tu kecil ke? Apa masalah dengan mak tu? Mak sendiri tu ada masalah ke tidak? Any disabilities, xanthoma misalnya, infection, scleroderma ke, don't forget about that, because this is an open title, yeah. So that would be the 3rd paragraph. The 4th paragraph would be on the management starting from 7 weeks, yeah. Kat situ ada berapa markah? 1, 2, 3, 4, 5, 6, 7 markah. Ya, 7 markah kat situ, banyak markah kat situ. Maknanya starting from 7 weeks, apa nak buat? From 7 weeks to, remember this is AMA, advanced maternal age. So from the very basic, we tak tahu probably that 2nd trimester or 3rd trimester, 3rd trimester can be caused by cervical insufficiency. You do not know, so that's why you need to have a cervical length surveillance, yeah, infections, yeah.
Prof boleh scroll Prof punya screen?
Oh, boleh. Don't worry je, Okay, ni tadi. Okay, ni ada 3rd paragraph tadi lah, ya. This is the, kita cakap tadi, markah dia 7 markah. Ya, kat sini, banyak markah dia dapat. Ya. And last but not least, you got 7 markah here, 1, 2, 3, 4, 7. Yeah, and don't forget about the 2 marks of the from conclusion. So again, apa conclusion nak tulis kat sini ya? Macam dah tulis semua kat atas kan? No, this is a wrap up. Yeah, it's a wrap up. So in this case, you want to say why is it important to trace the possible causes, and it must be a multidiscipline. Ya, kadang tu yang tulis kan tapi terlupa dari multidiscipline. Kadang selalu dah manage patient yang with multidiscipline sampai terlupa benda tu important. So it is important in multidiscipline. Anticipating of the recurrent, so you need to counsel and what is your overall planning about that. So in one sentence you kena masukkan benda-benda ni lah, isu-isu ni. Yeah, so senang-senang dapat 4 markah, 2 markah kat sini. Yeah, that's the conclusion. Selalunya jangan lupa about the conclusion, the intro and conclusion. People kadang use tulis itu pun nak tulis that conclusion, padahal that conclusion tu there is mark for you. Yeah. And again, kalau kita tengok balik semula, ya, kita tengok yang causes tadi, masa itulah tulis causes tadi, masa kita planning mula-mula tadi, bila kita tulis causes tadi, sebenarnya benda ni tadi dah sangat-sangat menenangkan you. This is like the web lah, mula-mula tu, causes tu. dah senang dah. Dah simplify your thoughts really. And so don't forget that in the thing, you must put down, and this is 20 marks and 20 minutes. Yeah, you're going to write essay for 20 minutes. Yeah, so please jangan seronok sangat tulis tu. Forget to look at the time is 20 minutes. You seronok macam mana pun, markah dia still 20. Yeah, kalau you tak tahu macam mana pun, markah dia masih lagi 20, the full marks. Yeah, so please try your best. This is a clinical title. So I think you should, and kalau nak dapat markah banyak pun dalam essay, is the clinical. Ya, clinical tu maknanya dia macam ikut you punya experience kan. Takkanlah you tak tahu dah manage all this while, dah 4 years already. 4 years tu yang ngam-ngam ni tau. All this experience before, takkan you tak tahu kan. Adalah sikit-sikit yang tertentu. Jadi bolehlah korek-korek markah tu. It's not like administrative punya essay, atau it is not like all the essay yang high-fi yang susah punya tu. This is a clinical. So you should
ada satu soalan. Kalau if they want to quote any statistical value or percentage from the paper, what is the value error margin that is acceptable to quote anything? Statistic.
Itulah kita nak sampai quote edge berapa tak ada. You quote daripada mana you ambil. Kita tak kata ini kita study lain tak. Kita nak tengok daripada mana study mana, you quote daripada mana. You ambil WHO ke, COG ke, NASDAQ, whatever is, please quote. Tapi daripada mana you ambil benda tu? Kita tak kata you salah, bukan you yang buat kajian tu. Yang buat kajian tu orang yang that person that you quote tu. So please put down, you quote from where. Itu yang important. So okay, I can share with you some tak apalah, nantilah later. I can email to the secretariat some of the papers that I can I refer during the marking of the essay. Kena ada refer juga, referrals juga kita buat ni. Essay ni bukan kita buat ikut kita punya grandfather story. So there must be, remember this is an exam, so kena ada code. Kena code statistics ke, orang ni cakap macam mana ke, from which ke, WHO ke, NASDAQ line ke. So sebenarnya tak susah sangat from your clinical experience lah. Macam aspirin, calcium tu dah boleh code dah. Kan korang tengah buat tentang essay tentang tentang PE semua, dah boleh code benda tu dalam you punya management tadi. Mana is part of the show that you have read something that is scientific. So
Prof,
any question?
I have a question.
Tak dengar, tak kuat sangat. Dia cakap boleh kuat sikit.
Huda, Prof.
Ya, Huda.
I'd like to ask a question. Following the formats that you give for management paragraph, what I've foreseen it, I answer it bila saya explain pasal blood investigation. I will explain FBC, PE profile, blah blah blah, and then cervical length less than 2.5 cm, blah blah. Anti-scan performed at 11 to 13 weeks. Do we need to go for detail or
tak payah detail. You nak cakap apa kat situ? Apa point yang cakap kat situ? So kata you want to exclude infections, such as apa you want to do? You want to look you want to do tortures ke, you want to do apa maknanya you want to do lah. Tapi you nak terang kat situ why you want to do that, particular investigations. Macam cervical length, you want to look at any forms of cervical insufficiency. So you want to do this cervical surveillance.
Tapi tak perlu mention lah Prof kan, paneling berapa measurement.
Not in detail. We're not talking about preterm labor, We're talking about IUD, kan?
And then macam aspirin calcium semua tu, we don't need to mention about the doses.
Tak payah dosage tu semua. Cakap lah aspirin as advocated by siapa-siapa. From apa, aspirin and calcium ni. Tak payah cakap in detail kena ambil 150, kena ambil malam. Tak payah. Itu benda tu je. Apa kepentingan dia. Okay.
Thank you, Prof.
So this is the first essay. Don't feel so depressed, and I know that you people have done a good job and you've started all the essays. Inshallah you'll do it. Don't worry. Provided you must be do your hard work lah, insyaAllah.
Thank you. Thank you very much, Prof. Dr. Noor Azlin. So with the interest of time, I would like to welcome upon Prof. Zaliha Abdul Mahdi for our second obstetric essay discussion. Welcome, Prof.
Assalamualaikum and good morning to all. Okay, the second essay is on persistent proteinuria in pregnancy. Yeah? I know I haven't written your scripts yet, although I've marked them for quite some time already, because I wanted to look through and point out if there is anything that I need to highlight from your answers. Yeah, okay. And before that, we have I think about 30 minutes to go through this. I will go through the answer scheme first. Okay, the standard answer script. I'll share screen with you. Okay, can you see? Nampak ke?
Yes, Prof.
Yeah, okay.
Yes, Prof, yes, nampak.
Okay, right. So the question is discuss the management of persistent proteinuria in pregnancy. Okay, I've underlined the keywords as you should always do when you get a question. What are the keywords? The keywords is discuss. That means you don't only describe, but you tell the whys, and if there is any controversy or debates around the issue, you can bring it up. Okay. It's management, so everything from the cause, the clinical features, investigation, management. Okay.
Sorry, Prof. Can you put your slide into the full view so that participants?
Yeah. Sorry. I forgot
Thank you.
Yeah, slideshow. Yeah. Okay. Right. Yeah. Is that better? Okay.
Yes, Prof. Yes, thank you.
Okay. Right. The management, and then it's persistent proteinuria. Okay. Yeah. The word is persistent. Okay. Please remember that. All right. So in the first place, what is the definition of proteinuria in pregnancy? Very often for essay questions, when you get a particular topic, define the topic first so that you know where your scope of discussion is. Okay, I'm pointing this out because quite a number of you said proteinuria in pregnancy can be physiological. I said, what? Because if you go by the definition of significant proteinuria in pregnancy, that means that is what you call proteinuria in pregnancy. If it is less than that, you don't call it proteinuria in pregnancy. It is acceptable as normal. Then you would know that it is pathological. It is not the physiological one that we are talking about. Okay. Of course, we all know that, the proteinuria in pregnancy, the quantum is more than in a non-pregnant person. Okay, in a non-pregnant person, up to 150 milligram per 24 hours is considered as normal. Anything more than that is pathological. But in pregnancy, it goes up to 300. So first, you put in your definition so that you know your scope of discussion. That defines the scope of the discussion that you're going to put here. That means, okay, you know already, it's 300 milligram and more. Anything less than that doesn't masuk dalam your discussion, your whatever you put here. Tak masuk topik, yeah, keluar dari topik. Okay, then the causes. Okay, causes of proteinuria in pregnancy. Of course, there is the transient one and the persistent one. The transient one, you can just say in one single sentence to just rule out the whole thing. Okay, you just say transient mostly in UTI, usually less than 1+, and this is not included in this discussion. Many of you go on and describe a lot about proteinuria related to UTI and then come up with management, give antibiotic and all that. Itu sudah keluar topik. Okay, so the physiological one keluar topik, the UTI keluar topik. Okay, yang masuk topik is only the persistent one. So you wasted a lot of your energy there already. Okay, so I hope you understand and can appreciate that. All right, so sebab itu, it is important to define, and then if there's anything that is maybe related but not really within the scope, you rule that out first. Say, I'm not going to talk about this. Okay, I'm just going to say, yeah, I know this exists, but this is not within what I want to say today. Okay. So the persistent one, you have before 20 weeks, all right, and after 20 weeks. All right, kalau before 20 weeks, of course, chronic disease. This goes for almost any medical problem in pregnancy lah. Yeah, kalau before 20 weeks, biasanya not related to the pregnancy itself. It is incidentally there because of some chronic disease. Can be primary renal disease, SLE, or other connective tissue disorders, diabetes with nephropathy, okay, and chronic hypertension also with nephropathy. Okay, and after 20 weeks, it is if there is persistent proteinuria, then you have to consider the possibility of the patient having developed preeclampsia, all right, or it may be just simply gestational proteinuria without any hypertension. And what is the significance of this? Okay, some of the papers will tell you, okay, a significant proportion of patients in this group actually goes on to develop preeclampsia. Okay, so that, and people are also now talking about preeclampsia without hypertension. Okay, so that is another thing. All right, so just briefly mention that, those kind of things. Yeah, gestational proteinuria, significance dia apa, relationship to preeclampsia tu macam mana. Okay, in new onset of a chronic disease, any one of these chronic disease can suddenly appear in the second half of pregnancy. Okay, it is just coincidental. All right, so that's the other thing. Okay, so then we go to the next one, clinical features. Okay, clinical features depends on the cause, of course. Yeah, this is common sense lah. Yeah, but most of the time it is asymptomatic. Okay, I'm sure you agree with me. Okay, most of the time proteinuria is asymptomatic and detected at routine antenatal urinalysis with few exceptions. These are the ones where there can be some symptoms and signs like nephrotic syndrome with all the NSACA and all that. Okay, SLE, okay, malar rash, whatever, you know. You don't have to be very detailed in giving the whole list of problems or clinical features related to each one of them. Suffice for you to let us know that you know that these are the conditions where there is certain features. SLE, you kata, for example, malar rash and joint pains, cukup. Done. Okay, tak payah nak panjang-panjang. Okay, as you can see, there's 2 pages of this PowerPoint pun. So kalau you nak tulis pun dah banyak dah sebenarnya. Kalau you just elaborate sikit-sikit aja, all those points that I put up here, yeah. Long-standing diabetes mellitus, okay, there may be other features like neuropathy and all that, yeah. Okay, glove and stocking, neuropathy, that kind of thing. Okay, chronic hypertension, hypertension, okay, which may or may not be related to the preeclampsia depending on when you detect the proteinuria. If it is in the second half pregnancy, hypertension will be part of the signs, okay, in relation to preeclampsia, or otherwise it is part of chronic hypertension. Okay, so preeclampsia, the patient may present with some symptoms of impending eclampsia, maybe, okay, and or some excessive edema or whatever. All right, the usual symptoms and signs. Investigations, there are 2 purposes for the investigations into this thing. One is for confirmation of the proteinuria and assessment and monitoring of the severity and progression. Okay, for this you can use a few known methods, like for example 24-hour urine protein, which is the gold standard. You can mention that. Okay, the strength and weaknesses of each of the method. Just briefly, UPCR, okay, and spot urine protein, or you may want to investigate for the purpose of finding the cause if you think this is in the first half of the pregnancy and there is an underlying chronic cause. So you investigate for SLE or CTD markers, and what is the role of renal biopsy and when do you think is a reasonable time to do renal biopsy? Okay, I know it is controversial, just one single sentence on the controversy. Okay, monitoring of the proteinuria. Okay, in the monitoring of such patients, you must be aware that there is a high risk of the patient developing preeclampsia, no matter whether it appeared in the first half of pregnancy or the second half of pregnancy. Okay, if the patient is not a preeclamptic patient yet, if any of these medical problems can lead to a high risk to develop preeclampsia. Okay, so serial ultrasound scan for fetal growth, because IUGR may be a feature, okay, for many of these medical problems. All right, and prophylaxis against preeclampsia if it is detected early enough. All right, if the proteinuria is detected early enough and the disease is detected early enough. Okay. Multidisciplinary management is the keyword in the management of such a problem. Okay, it's a combined management with nephrology, or I know in district hospital or the smaller peripheral hospitals with specialists, you may not have nephrologists. You may have a general physician, so that's fine. Okay, and don't forget long-term follow-up, because there is a high risk of cardiovascular disease in all these patients. Okay, for one, if they are already memang chronic medical problem, okay, or even if they are preeclamptic patients, there is a high risk of cardiovascular disease in the long term. Okay, hypertension, heart disease, and so on. Okay, so itu saja actually. Yeah, briefly, that's all there is. I'll stop share first. Okay, I can share back afterwards if I need to. Okay. And I do have a reference for you all. Wait, I put the apa ni. You can actually snapshot my two screens just now if you want as the sample answer. And I've got the link. Wait, hang on. The link to the a paper, which is very convenient for your answer. Okay, you will find all that you need for this answer in that particular paper. Okay, right. Okay, this is the paper, the PDF itself. All right, so you can download the PDF. All right, if I may show you the paper itself, it looks like this. This is the paper that I'm talking about. Okay, very recent, 2019. Okay, Frontiers in Women's Health review article. Proteinuria in pregnancy, a review. See, everything you want to know about proteinuria in pregnancy, the exact answer to your question kat sini semua ada. Okay, so if you have been reading well enough, you'll be able to answer. Okay, of course you don't answer like every single word from here lah. Okay, as long as the key points, as I mentioned just now, tu ada, that's good enough. Yeah. But the deeper learning that you need, I always believe in deep learning. Okay, if you learn deep enough, you'll be able to give the brief points that we want. Okay, so all are here. All right, UTI pun ada dimension as a transient thing. All right. Okay, so that's it. You can download the paper. And right, any questions? Anyone? So Alan, please. Oh yeah, before that, I go through your answer script too. Okay, some of you have such bad, illegible handwriting. Please do something about it. Sangat-sangatlah menyeksakan membaca. Bila sangat menyeksakan, you can understand how the examiner feels, and don't blame us if your markah tak secantik orang lain, ya. Because memang it is human nature, okay? Kalau susah sangat nak baca, because the thing is sometimes we don't even understand what you read, what you write. Ya, tak boleh nak baca pun, tak boleh nak faham apa yang you tulis. Okay, many of you have got the points there already, tapi not very well organized. Okay, and some not in enough depth. Okay, terlalu superficial. Okay, and for some there's a lack of reasoning and evidence. You just say something, tapi tak ada tak ada reason out why you do something. You say you want to do something tapi tak cakap kenapa. Okay. And long term kebanyakannya tak tulis. What is the need for the long term follow up tu tak ada langsung. Okay, yang fisiologi tu, aduh, ramai betul kata. This may be physiological. Hello, we are not talking about physiological proteinuria, yeah. Okay, it's not within the physiological range. Alright. Yang elaborate a lot on UTI tu ramai. Okay.
Assalamualaikum, Prof.
Yeah, boleh.
I have a question, Prof.
Sure.
As the title given was discuss management, what would be your suggestion on how we want to organize the paragraph for management? Is it one paragraph encompass one diagnosis and explain how to manage that diagnosis, or we can inside one paragraph all?
Okay, now, whenever a postgraduate question ask you about the management of something, okay, a clinical condition, yeah, okay, you have to have reasoning for your management. And the best way is to start off with what are the underlying causes ke apa tu. You know, when you're clear about what are the causes, what is the scope of your management, then only you go on to talk about your management. That's why I put the causes dulu. That's how you answer. Okay, you tell us first, what is it that we are looking for? Because kalau you tak define your scope of argument dulu, bila you cakap pasal management, habis bintang petang rata-rata you pergi. You know? So, I know many of you jump straight into the management. You know, the clinical, the symptoms, the signs, the investigation, the treatment and all that. That is not the way you manage or you handle a question on management. In order to write about management or discuss about management, you need to know the underlying reasons. Clinical reasoning is very important, especially at postgraduate level.
Okay, Prof. So do you have any good example on how does any candidates answer for example pre-eclampsia management?
Why would you ask, why would you manage, why would you elaborate about preeclampsia management? Ini kan persistent proteinuria. Kita tak tanya management of preeclampsia. You see or not? That's why I said, dekat awal-awal lagi, you letak dulu what is the scope. What is the definition of persistent proteinuria? What are the causes? So all your management will focus around the whole topic of the causes of persistent proteinuria. So you have to cover not only preeclampsia. What about gestational proteinuria? What about the other problems? When you come to the other problems, then it has to be multidisciplinary management because they are medical problems. Primary kidney disease, SME, and whatever else. Nampak tak? I do not expect anybody to tell me the whole lot about preeclampsia punya management. Nothing whatsoever. That's not the way you answer.
Prof, there is two questions in the chat box. For the first question, the postpartum management and long-term follow-up, can we put in the contraception, breastfeeding, and subsequent pregnancy plan? And the second question, how we approach courses, Prof, you suggest to approach the courses more than 20 weeks and less than 20 weeks. What about if we approach the renal courses and non-renal courses? Thank you, Prof.
Okay, now the first question, postpartum management and long-term follow-up to contraception. Well, if you want to put in, can in terms of the importance of preconceptional counseling, but you don't have to go into the details of what are the methods of contraception, apa semua. You see, what we want is the big picture first. All right, like what I put into my 2 slides. Tadi nak buat the 2 slides tu pun jenuh, banyak actually points kat situ. and there's a lot that you can elaborate from there. You know, if you have time to elaborate on the methods of contraception, up to you. You can have a bit of sikit-sikit bonus markah lah. Okay, tetapi yang kita nakkan the framework tadi tu, the big framework. That's why kita kata sebelum you jawab, seeloknya you buat dia punya rangka dulu, rangka jawapan. Okay, do the framework for your response or your answer first. Okay, we do look at that as well when we mark your essay. All right, how the important thing is your thought process. How you put your thoughts into this. Bukannya mana yang you boleh tulis, detail mana yang you boleh tulis. It is not the details. It is the big framework. That's how a pakar thinks. You're not at the undergraduate level. Undergraduate, yes. What is the management of preeclampsia? Very focused. Preeclampsia saja, all about preeclampsia, very detailed. Yeah, itu undergraduate. But for postgraduate, it is the big picture that encompasses many conditions. So that's my response to the first question tu pasal breastfeeding apa semua tu. Not as important as the big framework. Okay? Right. And approach courses more than 20 weeks. Okay. Now, renal courses and non-renal courses. Do you mean to tell me that the pre-eclamptic a course for proteinuria is not renal? It is renal, isn't it? Renal glomeruloendotheliosis that caused the proteinuria. So how can you say it is non-renal? This is proteinuria. The basement membrane is leaking protein. You see or not? Definitely not reasonable to say it is renal and non-renal. All of them are actually renal, only that whether they are primary renal or secondary to some other disease. Nampak ya? Dalila? And on top of that, because you are asked how to manage, how do you approach? So clinically, it's easier to approach less than 20, more than 20. When you see the patient, do you know this is renal or not renal? Investigate pun lagi kan? Okay. So approach from the practical, clinical point of view. Kalau you nak buat algorithm, macam mana you nak manage this patient. Easier for you to classify less than 20, apa aku nak buat. After 20, apa aku nak buat. Okay? Yes, any more questions?
All right, thank you very much, Prof. Zaliha. Without further ado, I would like to welcome our Associate Prof. Dr. Rahana Abdul Rahman for our next session, our subject essay discussion 3. Welcome, Prof. Rahana.
Thank you.
I'll share my screen first. Yeah, can you hear me, Roida?
Dengar, Prof?
Okay, can you see my screen?
Belum, Prof. Tak nampak lagi.
Tak nampak eh. Sekejap ya. Okay.
Yes, Prof. Dah nampak.
Tak nampak?
Dah nampak, Prof.
Oh, dah nampak. Okay. Okay, Assalamualaikum and good morning. The topic for the essay given to me to be discussed today is critically appraise the management of pregnancy with non-immune hydrops vitalis. I think similarly, like Prof. Zaliha, there are a few students with very bad handwriting. Yeah, so it's difficult to read and it takes time to read through what you have written on your paper. That's number one. Number two, there are a few, I think, no, maybe not a few, one or two, who had actually copied and pasted from the internet into your answer script. I don't understand why you did that, but that defeats the purpose of you attending this course. Yeah. Right, anyway, we'll go straight to the essay. So non-immune hydrops fetalis, basically you have to discuss on the causes of hydrops fetalis, which is not due to your red blood isoimmunization, yeah? So causes, there are many causes for the non-immune hydrops fetalis, right? Such as cardiac causes, for example, the arrhythmias like SVTs, cardiac tumors, and also hypoplastic left heart. Chromosomal problems such as your trisomies, your Edward, your T21, which is Down syndrome, and also Turner syndrome. And infections, for example, parvovirus B19, which is well known to cause hydrops fetalis, and also CMV, and also syphilis. Tumors such as acrococcygeal teratoma, and also placenta chorioangioma, and also hematology cases like HB buds, and also TTTS in your multiple pregnancy. Right. So when you write your answers for this essay, so this is like going through what you are thinking in your head. Yeah. Whatever you think in your head, the thinking process, when you come across such a case, you should be writing it down in such a way. So when you see a patient with a hydrops fetalis, so the next thing you want to do is you're going to first list down all the causes, and then you try to assess by history and also physical examination. Right. So the clinical evaluation, you should have a detailed history and to focus on the all the history that the patient has. For example, past medical history for any blood disorders, the past obstetric history for any similar problem, right? And also the social history, for example, consanguinity in the marriage. And secondly, you have to make sure that the patient's dates are correct, and also any history of viral exposure or illness during this pregnancy, and also any use of medications. Okay, and your examination should be aimed to rule out. Number one is to find out the possible causes of the hydrops fetalis. Number two, you should also look out for complications arising from the hydrops fetalis. So your investigations are going to be based on each causes that you have listed out down in your sheet. For example, a bit more urgent will be your fetal ultrasound. So once you see a hydrops fetalis, the next thing you want to do is, of course, you want to have a detailed ultrasound to look at each system, whether there is any structural abnormalities, right? And also the next thing you want to assess is whether this hydrops fetalis is due to anemia. So they can do a Doppler examination. And if you suspect or if you see there is a structural abnormality of the heart, then there is a role to bring in a fetal cardiologist to perform fetal echocardiogram. As for the mother, you can withdraw blood to perform some blood investigations, such as a simple full blood count to see whether you are dealing with a thalassemia. Right, so we don't discuss about the ABO and indirect circumstance, yeah, because this is a non-immune. So you may want to consider immunological laboratory test, for example, to look for syphilis, or you want to look out for parvovirus B19 infection, and of course your torches. And as you can see here, liver function test, uric acid, coagulation test, if you are suspecting a Muir syndrome, which is a complication of the hydrops fetalis. Now, just to correct some of you who had written, the Muir syndrome is the cause of hydrops fetalis, which is not true. It's the other way around. Yeah? Because of the hydrops fetalis, you can have a Muir syndrome. As you can see, for any causes that involves arrhythmia, for example, fetal bradycardia, yeah, so you would want to look out for any associated connective tissue diseases. Right, so the ethnic origin this ethnic origin is important especially when you're considering the cause is due to thalassemia. So it's good to mention about your Doppler examination because the peak systolic value, velocity is of the hydrops vitalis. So a simple Doppler examination will tell you a lot of things. Right. So other investigations, whether you want to do amniocentesis and karyotyping, that again depends on what you are dealing with. Yeah? If you are suspecting a fetal chromosomal anomaly, of course you would want to perform amniocentesis and karyotyping. I don't think that we make it a practice over here to perform amniocentesis just for to send off your amniotic fluid for infection, but that it can be considered. In cases of when you suspect that the fetus is anemic and you want to look at the actual hemoglobin level of the fetus, then you have to mention about fetal blood sampling, because via codosynthesis. Yeah? So you can actually look at the fetal blood to look at the level of hemoglobin. You can also send it off for if you want to confirm thalassemia, right? And also you would want to, with the same investigation, the blood that you have gotten, you can also send off for other investigations, just to rule out the other causes such as tortures. Okay, so other investigations will be your cavity aspiration, which we rarely do. And also, I think most of the students, most of you all had forgotten all about the placenta and also postmortem. Yeah. So the post-delivery part is also important for you to counsel the couple whether you would want to send off the placenta for HPE. Yeah? And also postmortem is also equally important for to be counseled to the couple. Yeah. So in the examination of the placenta, this is if you are looking at neonatal survival. Yeah? You have to look at the detailed physical examination of the fetus, of the neonates, once the neonate is delivered. And whatever you have assessed in the post-delivery period will be based on what you have suspected earlier on during the antenatal period. Okay. In the event of a neonatal demise or fetal demise, these are the investigations that you should consider to be done. The autopsy is actually very important, which I think most of you have missed. Okay. In cases where you think the cause of the non-immune hydrops vitalis is something that you can intervene and try to improve the neonatal outcome, then there is the role for fetal therapies. For example, for intrauterine transfusion for anemia. Now, you can consider this if you're suspecting or you confirm that the cause of the fetal anemia is due to parvovirus B19, right? And some other interventions antenatally in cases where you don't think this is due to something little, such as, for example, HB buds. Yeah? So you would want to consider performing some interventions just to relieve the fetus from the ongoing insult to the systems. For example, if the fetus has a lot of pleural effusion, so you want to consider doing a tapping of the pleural effusion just to relieve the lungs from the insult, and hoping that there will be lesser of the problem and improve the neonatal outcome. In fetuses that you come across hydrops vitalis, and you can see that there is a fetal tachyarrhythmia, then you should consider giving antiarrhythmic drugs, which usually gives a good outcome to the neonate. Same goes for other causes such as twin-to-twin transfusion syndrome. Then there is a role for your laser ablation, and also sacrococcygeal teratoma, although there are some centers, I think not in this part of the, not in our country, that they perform a surgery in utero. We don't do that here, but there are some centers in the developed countries, they actually perform procedures for sacrococcygeal teratoma. If you suspect the fetus has hydrops fetalis due to a maternal grave disease, for example, or hyperthyroidism, which is uncontrolled, then there is a role for treatment of the mother with the antithyroid drugs, and that can actually improve the fetal outcome. Okay, so this recommendation that I've listed down is actually taken from the Canadian guideline. Yeah, so what is written here is all patients with fetal hydrops should be referred promptly to the tertiary center for evaluation. Some conditions amenable to prenatal treatment represent a therapeutic emergency after 18 weeks. Yeah. Number 2, fetal chromosome analysis and genetic microarray molecular testing should be offered where available in all cases of non-immune hydrops. Imaging studies should include comprehensive obstetrical ultrasound, including the Doppler examination and also fetal echo. Number 4, investigation for maternal fetal infections and alpha thalassemia in women at risk because of their ethnicity should be performed in all cases of unexplained fetal hydrops. Number 5, to evaluate the risk of fetal anemia, Doppler measurement in the middle cerebral artery, PSV, should be performed. And in the case of suspected fetal anemia, fetal blood sampling and intrauterine transfusion should be offered rapidly. Number 6, all cases of unexplained fetal hydrops should be referred to a medical genetics service where available, and detailed postnatal evaluation by a medical geneticist should be performed on all cases of newborns with unexplained non-immune hydrops. And the last, autopsy should be recommended in all cases of fetal or neonatal death or pregnancy termination, and amniotic fluid and or fetal cells should be stored for future genetic testing, which is not, I don't think it's available in our center here. Not sure about other centers. Right, so I'll stop sharing now. So my comment regarding your answer sheets, I think most of you have had gotten the answers somewhat, but it's all disorganized. So the way to approach the essay question is typically like what you're thinking when you come across a patient in your daily duties. Yeah? So you go by history, and then you go by examination, and the next will be your investigation, and the last will be your management. Okay. Thank you very much. Any questions?